The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/JDM860. Downloadable infographics are also available. Thank you for listening to Peerview Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Hi, this is Dr. Peter Goadsby from the University of California, Los Angeles and the NIHR Wellcome Trust King's Clinical Research Facility and SLAM Biomedical Research Centre at King's College in London. Let me welcome you to this educational activity entitled Addressing Unmet Needs in the Acute Treatment of Migraine. Focus on the role of 5-HT1F receptor. Today's infographic-based activity is divided into 3 sections. First, we'll talk about the general guidelines for diagnosis and treatment approaches to migraine. We'll then focus on the serotonin 1F receptor agonists as treatments for acute migraine. And then I want to consider some of the patient perspectives on migraine management. Let's hear a patient's story about their migraine diagnosis.
Thank you, Dr. Goadsby, for having me today. I've had migraines since I was about 10 years old. They were debilitating. I would have a terrible aura, violent nausea, and intense pain. And they weren't really believed at school because they would happen the same day each week, which was odd. And they thought that perhaps I was trying to get out of a class or I was being bullied. But they were really bad. And I remember my parents used to have to take me to the hospital and I would get a shot that would put me to sleep. And that would be followed up by the next day of, kind of like having a migraine hangover. And it was really tough as a kid living like that. So many of the triggers that can cause a migraine are things that kids love, like foods that have MSG in them and soda and sleepovers and all those kind of things can be triggers. After I went through my teens, they kind of went away a little bit. And then they came back when I was pregnant with my daughter. After I had her, they went away again. Then when I was about 45, they came back with a vengeance. That they were different and that they weren't quite as intense as they were when I was younger. I no longer had an aura and I wouldn't get as violently sick, but they would last forever, or it seemed like forever. They would last for months at a time. So when they came back when I was about 45, I first went to my primary care doctor and he said, they seemed like they were tension headaches, but I was unable to treat them. Nothing I took helped. My aha moment was finally when I saw an ear, nose, and throat doctor. I was thinking perhaps I was allergic to something. And he had asked me a significant amount of questions about my history, my diet, medications that I've tried. But he also asked me some unusual questions about my balance and did I have any facial pain or dizziness or phantom smells even. And some of these symptoms I had never heard before. And certainly no one had ever asked me before. But it turns out those are symptoms that I was having that are associated with migraine.
In the first section, I'm going to deal with migraine guidelines, diagnosis and general treatment approaches. The first thing that's important is to make the diagnosis, to identify the patient with migraine, which hopefully can be done simply and require not terribly much time. And it's absolutely important to get the diagnosis because otherwise one can't really decide what treatments one might want to use. There are a number of screeners that are available: the Migraine Screen Questionnaire, MSQ, ID Migraine, and the 3-question Headache Screener. My personal preference is for ID Migraine, developed by Richard Lipton and his colleagues, highly validated, very simple to use, and very practical, I find, to be able to screen for patients who may have migraine. More than 90% reliability. It's a very good screener. Now, when we come to the diagnostic criteria, the International Classification of Headache Disorders in its third edition have criteria for migraine without aura and require at least 5 attacks, typically lasting between 4 and 72 hours, with certain features, so one-sided headache, pulsating, moderate or severe intensity, and aggravation of the pain by routine physical activity. Patients also should have nausea or vomiting, and light or sound sensitivity, photophobia and phonophobia. Migraine, if you like, is a syndromic diagnosis. You don't have to have everything, you need to have something, and you need to be flexible as you listen to the patient's history. Migraine with aura is similarly diagnosed with a syndromic approach. So patients ought to have the aura symptoms, the fully reversible symptoms, visual symptoms, that's flashing jagged lights, or sensory symptoms, pins and needles moving across the arm or leg, speech or language dysfunction, and more rarely, weakness down one side of the body, so-called hemiplegic migraine, or symptoms that you could refer to the brainstem, like double vision, tinnitus, vertigo, or dysarthria. These symptoms crucially need to spread. It's really the thing in migraine aura that when patients will describe the slow spread of symptoms taking minutes going up a limb, or the visual symptoms taking minutes to develop, you really have the diagnosis pretty much nailed. For typical aura, ICHD would like it to last no more than 60 minutes. If it lasts longer than 60 minutes, we think about it as being prolonged. The aura, at least one of them, will be typically unilateral, and of course it can be accompanied by headache, usually within about 60 minutes. Now, we only need 2 of those to fulfill the strict ICHD criterion, just as with migraine without aura, migraine with aura. The ICHD has a get out of jail card, you might say, that it's not better accounted for by another diagnosis. And of course, in aura, it's important to have thought about and to have excluded a transient ischemic attack. In essence, episodic migraine is headache on less than 15 days a month, and chronic migraine is headache on 15 days or more per month, where there's a link to migraine. The patient may also believe the attack to be a migraine and have it treated with a triptan or an ergot. 15 days of headache and 8 days where at least they fulfill these migraine criteria are the formal chronic migraine diagnostic criteria. And of course, the 15 days is a somewhat arbitrary line in the sand, and we've learned to live with it. I'm sure that with time, we'll be able to understand that better. The important thing for patient, a core essential aspect, is to understand why they came to see you. What are they looking for? Are they looking for a better acute attack treatment? Are they looking for prevention? Are they looking for explanation? Perhaps they're looking for all 3. It's certainly true, I think, that if a patient comes along with migraine and wants to talk about their treatment, you at least need to be having a discussion about acute treatment, because every disabling migraine attack needs to be stopped. The indications for prevention, as recommended by the American Headache Society, include that the attacks should interfere with daily routine despite acute treatment. There should be a reasonable frequency, and we decided 4 or more would be reasonable. There could be a contraindication or failure to acute treatments, problems with adverse events, or indeed a patient preference. Broadly speaking, we think about patients that have more than 4 headache days a month. In some level, we would want to recommend prevention. It's a very important discussion to have with patients as to when they see the need for prevention. Because if the patient sees the need for prevention, it's so much easier to have compliance in the particular medicine that they use. Now, in general terms, for pharmacotherapies, for acute therapies, we're thinking about what we do about the pain and for the associated symptoms. And in fact, to get an indication for migraine, you need to be able to control the head pain at 2 hours and the so-called most bothersome symptom for that attack. In terms of established acute therapies for migraine, one could think of the first broad group as painkillers, analgesics. They tend to be more useful for mild to moderate attacks. We tend to recommend non-steroidals such as ibuprofen or naproxen. Of course, a problem with non-steroidals will be the associated GI side effects and the discussion around cardiovascular issues. Opioids are widely talked about and not largely recommended. In general terms, they're not as efficient as non-steroidals or indeed acetaminophen or the migraine-specific drugs we'll talk about, and their potential for overuse problems, tolerance, dependence, and the side effects contributing, for example, to cognitive dysfunction really make them a pretty poor choice for patients with migraine. The currently established acute treatments, migraine specific, are two classes. The triptans, the serotonin 5-HT1B1D receptor agonists that are available as tablets or injection or nasal spray, a number of formulations. They have their issues around ischemic heart disease and uncontrolled hypertension, and of course it's always complex to use any medicine in pregnancy or in nursing mothers. Ergots were the mainstay before the triptans. They're also agonists at the 5-HT1B1D receptor and agonists at a number of other receptors. Similarly, difficulties with vascular disease and poorly controlled hypertension. Their major advantage tends to be a longer half-life and so reduced recurrence. Their biggest problem can be getting an appropriate formulation because they're orally not bioavailable to speak of. In the last 6 months, we've had approved therapies by the FDA, two classes. First class, the GPANTs. These are CGRP receptor antagonists, and the two that have been approved are rimegepant and ubrogepant. They're very well tolerated drugs. They're available orally, and they're effective in the acute treatment of migraine. The other big class is the DITANs, selective serotonin 1F receptor agonists. Lasmiditan is the first in class. The most important contraindications are driving impairments, 8 hours, and some mild CNS depressant effects, again, available orally. It's just fantastic, I think, in clinical practice, having practiced with triptans for 20 years, to be able to have new options to talk to patients about, and they're not options where we have to be concerned about unwanted vascular effects of the drugs. In general, it's important to use an evidence-based when treating patients, and I think everything we've talked about is evidence-based. It's important to tell patients to treat as early as possible the first sign of pain and not wait till things are out of hand. It's useful to be able to have non-oral formulations for patients who have nausea or vomiting or difficulty swallowing. And it's important, of course, to understand the comorbidities and experiences patients had of previous medicines as one goes on and prescribe. Rescue treatment is very useful. I find it useful to give a patient a therapy for their attack and then give them a strategy for rescue so they don't have to go to an emergency room. Light, sound, smells, noisy, movement. All of the things that happen in an emergency room, generally speaking, make migraine worse. And so giving our patients confidence that they can treat at home and have control of the problem, I think, is terribly important. And then, of course, we need to avoid overuse so we don't create a problem with our acute treatments. I'm going to turn now to the serotonin 1F receptor agonists specifically and their use in acute migraine. So DITANs, which are certainly a different approach. Let's see how DITANs, serotonin 5-HT1F receptor agonists, might work in the acute treatment of migraine.
Migraine is a neurologic disorder characterized by distinctive, disabling headaches that last 4 to 72 hours and are often accompanied by additional symptoms such as nausea, vomiting, light sensitivity, and/or sound sensitivity. About 1/3 of individuals with migraine will experience an aura, temporary visual, other sensory, or other central nervous system symptoms leading up to an episode. In migraine, triggering events activate neurons in the trigeminovascular pathway, which relay pain signals to key structures in the brain. Neurotransmitters and neuropeptides convey signals from the trigeminal neurons to other neurons. Calcitonin gene-related peptide, or CGRP, is one of the neuropeptides, and it has been identified as playing a key role in migraine. CGRP may contribute to neurogenic inflammation through its effects on vasodilation and vascular plasma protein extravasation. It may also directly potentiate and prolong pain signaling. Agents in several medication classes have been approved for acute treatment of migraine, including ergots, triptans, CGRP receptor antagonists, and most recently, DITANs. Agents in these classes are thought to reduce migraine pain through actions that reduce CGRP activity. CGRP receptor antagonists for acute migraine treatment include rimegepant and ubrogepant. These agents block CGRP effects, including vasodilation, by preventing it from activating its receptor. Ergots for acute migraine treatment include dihydroergotamine and ergotamine, and triptans approved for the same indication include sumatriptan, zolmitriptan, rizatriptan, almotriptan, naratriptan, and frovatriptan. Ergots and triptans activate 5-HT1D serotonin receptors on presynaptic neurons, inhibiting CGRP release. The triptans also have activity at the 5-HT1F receptor, which could contribute to their actions. Preventing CGRP action by blocking receptor activation or inhibiting its release also prevents CGRP-mediated vasodilation. However, ergots and triptans act via 5-HT1B receptors to cause vasoconstriction. While this counters the effect seen in migraine, it also has the potential to increase cardiovascular risk. Consequently, ergots and triptans are contraindicated in people with vascular disease. Lasmiditan is the first approved agent in the ditan class. It is highly selective for the 5-HT1F receptor, and lasmiditan binding at presynaptic 5-HT1F receptors prevents CGRP release. In addition, activation of 5-HT1F receptors may have an inhibitory effect on CNS pain pathways. However, lasmiditan does not have significant activity at the 5-HT1D or 5-HT1B receptors. Consistent with this binding pattern, it does not cause vasoconstriction, and its use is not restricted in people with cardiovascular disease.
CGRP is widely distributed in the central and peripheral nervous system and the cardiovascular system. CGRP has been linked to migraine in several ways. It's increased in the early parts of the spontaneous attack. If you infuse CGRP into a person, into a migraineur, then they will develop an attack which is indistinguishable from their typical attack, and the levels of CGRP will be reduced with attack control after a triptan. If one then turns to serotonin in the context of the pathophysiology and links the two things together, it's useful to think about the potential receptor involvement and the places in the brain, in the central nervous system, and indeed in the whole pathway, where serotonin receptors may be involved. I mentioned that the triptans were serotonin 1B, 1D receptor agonists. In fact, some of them are also 1F receptor agonists. What we do know is that triptans can inhibit CGRP release and in fact turn off neuronal transmission in the central nervous system. And not only do they turn it off in the trigeminal nucleus caudalis complex, but the triptans can have effects within the thalamus, in the sensory thalamus, the ventroposterior medial thalamus, and in the periaqueductal gray, modulating pain control systems that are involved in migraine. The serotonin 1B receptor is the vasoconstrictor receptor, the blood vessel, the 1B receptor. In fact, historically, it was really the target that was gone after by Pat Humphrey and colleagues to develop triptans. The question that had always been posed since the development is whether it was necessary to constrict vessels, because certainly we don't want to constrict them if we don't have to. So when I look at the various classes that we have of the acute treatments, when you think about them by their mechanism of action very broadly, all of the current classes will inhibit the CGRP pathway, be it ergots, triptans, and ditans, which stop the release of CGRP from prejunctional or presynaptic nerve fibers, or GPANs, which actually are receptor blockers, CGRP receptor antagonists, so they block the effect of CGRP. If one thinks about the brain function, the neuronal function, be it in the trigeminal ganglion or in the nucleus caudalis or in the thalamus, all of these structures, ergots, triptans, and ditans will inhibit neural signals, as will indeed GPANs. Vasoconstriction, however, is limited to ergots and triptans because of the 1B effect. GPANs don't affect the 1B receptor, and the ditans are deliberately being constructed not to affect the 1B receptor. What does that produce? Well, what's clear is that if one looks at, for example, the middle meningeal artery, or indeed look at coronary vessels, that the effect of a 1F agonist, and lasmiditan is the exemplar of the class, it's now available clinically, it doesn't have effects on vessels because 1F receptors are not on vessels, they're on nerves. And then when one looks at the pharmacology of lasmiditan, it's clearly not active at either the B or the D receptor, but highly active with excellent affinity and potency at the 1F receptor. So what happens clinically with a 1F receptor agonist? The two pivotal or phase 3 trials were called Samurai and Spartan, and they looked at a range of doses of lasmiditan, 50, 100 and 200 against placebo in a parallel group placebo-controlled trials. The primary endpoint was 2 for regulation, pain-free at 2 hours, and for all of the doses, 50, 100 and 200, lasmiditan outperforms placebo at the 2-hour mark. The co-primary that's required for registration is freedom from most bothersome symptom. So for the attack, the patient nominates which symptom of nausea, photophobia or phonophobia is the most bothersome. And by 2 hours, that has to be gone for that attack to count as a success. And again, for each of the doses of lasmiditan across both of these large phase 3 studies, the lasmiditan outperformed placebo for most bothersome symptom. And the combination of the two co-primaries with the two large studies led to its licensing. It's clear that patients do well on effective acute therapies, and 1F receptor agonist lasmiditan is an effective therapy. They have less disability, a reduction in MIDAS score, for example. If patients have a history of a poor response to a triptan, they're still just as likely to have headache freedom and freedom from most bothersome symptom and indeed pain relief across the range of doses. So patients who've not done well on a triptan certainly are candidates for trying lasmiditan. New medicine, what are the new side effects? Life is like that. Well, I'm happy to say that no one died in the Samurai and Spartan studies, and the actual adverse event rates are quite modest when you think about the broad symptomatology that patients have with migraine. Dizziness, some pins and needles, and some tiredness are the most obvious ones, and there are others listed in the product information. The side effects are very similar in Samurai and Spartan, and not surprising when you look at the long-term study, it was called Gladiator. They reduced with time. There were no important serious adverse events reported in Gladiator. Now, cardiovascular risk is an important thing to pause and think a moment for, because I've talked about the fact that the 1F receptor is a neural receptor, that dietans are acute migraine treatments based on a neural mechanism of action. And they really did test the question, if I could put it this way, of whether it was necessary to constrict vessels to have an anti-migraine effect, and the answer turned out to be no. Cardiovascular AEs, quite a modest number, less than 1% in the lasmiditan phase 3 studies. Now, ischemic events, certainly no important ECG findings, and no difference in the cardiovascular side effects reported, whether the person had presence of cardiovascular risk factors or not. And similarly, in the extension study, the Gladiator study, no cardiovascular problems have been reported out, which is consistent entirely with the biology of the 1F receptor. So how do you take this? In my practice, it's fantastic to have something that I can use in patients who've got contraindications to triptan or who failed at triptan therapies. It gives the patients options and certainly makes practice increasingly a pleasure. It's important to document failure. Patients are usually very happy to tell you about the list of things, the side effects they've had and the difficulties that they've had with the therapies, and they're real difficulties. And I think one needs to remember that. I think it's important to treat more than one attack with a new therapy. Recommendations vary to 2 or 3 attacks. I think it's reasonable to at least treat 2, and my personal preference is to try and get patients to treat 3 attacks to really get an idea whether a new therapy is useful or not, assuming they don't have any particular problem with it. Keeping an eye on frequency and treatment efficacy is important, and trying to understand what the patient's preference is in terms of adverse events or experience or what they've heard about these various things. There are questionnaires to do that. The one I like is the MTOC questionnaire, Migraine Treatment Optimization questionnaire, again, that Richard Lipton's developed, very well thought through and can be quite helpful in documenting the need for acute therapy. Let's hear a patient's perspective on the challenges of migraine treatment.
Over the years, I have tried a significant amount of medications. Some that have worked, some that worked for a period of time, and some that didn't work. But there were some that the side effects were just absolutely unbearable. They caused cognitive issues. There were some beta blockers that lowered my blood pressure and just made me weak and tired. But there have been some that have really helped. most recently the CGRPs, GPANs, and Dietons. They're the first medications in years that have really provided me with any type of relief. When I have a migraine and I have to figure out which acute treatment to go to, it's a decision. There is one that works better than the other, and the savings cards only allow you, or savings programs only allow you for a certain amount per month. So I really have to wonder, should I take the one that works the best for me, or should I reserve that for a really bad migraine that might be coming tomorrow or the next week? I think the best advice for clinicians and for patients is to keep trying and have an open dialogue with your doctor. Go to a doctor prepared. Have a chart of what you've tried, what works, how often you're having them, but try different medications.
What are we trying to do with migraine treatment? Well, we want to restore function. Migraine doesn't kill anybody in the generality of things. It ruins their life. A migraine patient will tell you that they lose days. So reducing disability, putting them back to function is really great. I think enabling patients to be in control of their attacks is important, giving them a sense that they're back in control of the problem. And of course, as you do better, you actually reduce cost and resource utilization. It's terribly important that we're able to treat as many patients as properly as we possibly can, and to make sure they can control things so they don't need to be going along to urgent care or to emergency rooms when really they should have the tools at their own disposal. For preventive treatments, we want to reduce frequency and severity and duration of attack. I really think what we're trying to do is make their life predictable. People with migraine want to be normal. They want to be able to do the things they want to do. And that involves giving them very good treatments for their attack, and if necessary, reducing the number of attacks, which will improve, of course, their quality of life. For acute treatment, of course, we want a rapid effect. We want it to be consistent. Very important. Because if it's not consistent, they can't rely on it. If they can't rely on a treatment, they can't make plans. And if they can't make plans, they lose out life opportunities. So consistency and tolerability in that context are important. We don't want to have to redose them too often. We use rescue medications. And of course, we want to absolutely minimize the number of side effects that they might have so the medicine doesn't become worse than the disorder. What are the hallmarks of good care? Getting the narrative at the start is useful to get some idea of where the person's at, and I find it very useful to understand what they're kind of looking for out of the consultation. And sometimes it's more useful to get that subtly rather than just say, what do you want? Because that can often not lead anywhere very useful. I like to get the frequency, and I like to get the frequency of all headache. Very often patients will say to you, I've got 10 days a month. So what I'll call the bookend question is what they call in the psychology world, I think, ask, tell, ask, is someone says to me, I've got 10 a month. I will say to them, well, does that mean that you've got 20 days a month that are perfectly crystal clear normal? Because that's the implication of I've only got 10. And they'll very often say, well, no, maybe I've got, it's another 5 or 6 or something where I don't feel quite well. You've got to give them permission almost to tell you everything that's going on. It's not that they're whinging or moaning. It's that you're trying to get complete history, trying to understand how the headache affects them. What does it stop them doing? What are the limitations in your life? Goes without saying, as I said at the start, almost, you need to get the diagnosis right and to be able to differentiate migraine from other problems. And of course, counting up the headache days is important if you're going to make the diagnosis of chronic migraine to make sure that you can get all the therapies that you might want to have for the patient. I find it really important to give them a clear treatment plan, to understand what we're going to do, and realistically, what do I think you can achieve from the treatment plan that I'm giving you. That's why rescue is important, because the first medication may not work for every one of your headaches, but I would like to have a way so you feel back in control. It's often said that asking open-ended questions is a good idea. I think it's got a place. I have to say I like some of the history to be done with actually closed questions and very clear questions, because there are many things about migraine that that the patient doesn't know. They might not know that you would expect them to have the premonitory symptoms and neck discomfort in the day beforehand. They may not know that you would expect them to have tiredness or yawning. They certainly may not know that you might expect them to pass more urine or to crave sweet or savory things just before the attack. They might not think to tell you that. You ask them that question, you get a clear answer, yes, out of that. You will have shown a person that you understand their problem, and you'll have enhanced your therapeutic interaction because as a physician who's interested in migraine, you know things. Anyone can Google things, but you know things and you know how to put them in a context. Let me make some summarizing remarks. It's clear to me that everyone with migraine who comes to see a doctor needs to be able to treat their acute attack as best as possible. And that means you need to know what they've had, what hasn't worked, what side effects they have, and give them a plan for what they're going to do next. Some of this might simply for milder attacks be analgesics, and sometimes it might be current migraine-specific drugs. And if patients are struggling, we certainly have the new classes of GPANs, rimagepant, ubrogepant, and the ditans, the 1F receptor agonist, lasmiditan. The AHS, the American Headache Society, has provided some guidance in recent times on their use for neuro agents, and I recommend it for your consideration. In particular, focusing on lasmiditan, certainly useful for patients with migraine, including those with cardiovascular disease. It's important that lasmiditan does not interact with the serotonin 1B receptor, so it has no vasoconstrictor effects because it is a selective 1F that's a neural receptor at the basis for its action. Thank you.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/JDM860. This activity is supported by an educational grant from Lilly. For further information concerning Lilly grant funding, visit www.lillygrantoffice.com. This accredited CE activity is jointly provided by Medical Learning Institute Incorporated, Association of Migraine Disorders, and PVI, Peerview Institute for Medical Education. For more information on understanding of migraine disease and its true scope, please visit the Association of Migraine Disorders website at www.migrainedisorders.org.